Dialogue with a Doctor, featuring Southwest Florida's leading physicians.
Good day and welcome to Dialogue with a Doctor show. We're here today with Dr. Pagliara. He's a practicing radiologist with Radiology Regional, and a good one I might add. And welcome back. And this is your first time on their show.
Yes, it is. Yeah.
He will be talking about cancer screening, lung cancer screening, the new guidelines, and CT screening, which we've never done that before, have we?
No, it's relatively new, and it's been an exciting change of pace as far as lung cancer screening that will be recognized by the Center of Medicare and Medicaid Services as an acceptable screening for lung cancer.
Before we get going, tell us a little bit about yourself, where you came from, who you are.
Yeah, well, my name is Richard Pagliara. I'm an osteopathic physician, and I originally am from Albany, New York, and did my residency in diagnostic radiology at Hartford Hospital, and then a fellowship at Stony Brook University Hospital in abdominal imaging, and came down here and joined Radiology Regional 2008, and been here ever since. It's a great place to live, work, and play.
So tell us about Radiology Regional. Where are your locations? How big of a practice is yours?
Radiology Regional, we are comprised of over 430 employees, 28 radiologists. We have 9 locations throughout Collier and Lee counties. The local Lee County offices from Naples would be Bonita and Estero, and then we have the designated Collier County office on Goodlet North and 7th, or Goodlet Avenue and 7th North, down by the Commons.
Yes, right across the street from my office.
Your office.
Thank you for helping us. You also have subspecialists in your practice?
We do. We have neuroradiologists, we have breast imagers, we have nuclear medicine physicians, interventional radiologists that do vascular work, general body radiologists like myself, and musculoskeletal.
Well, tell us about CT, CAT scans. We always use the word CT. CAT scans of the lung, the new paradigm.
Mm-hmm. Well, CT has been around for about 42 years now. Around 1973 is when it started to become a modality at the major healthcare institutions across the world. Computed tomography is otherwise what it's known as. And it does use ionizing radiation to penetrate the body, and we create images with that information. And the CT itself has become more and more advanced over the years with the number of detectors and the quality of the X-ray beam spanning over larger parts of the body to generate images with not only more detail but also scan the patient much more quickly. And recently, the Centers of Medicare and Medicaid Services, CMS, has agreed to now fund, if you will, or reimburse for this low-dose lung cancer screening test, which is for certain individuals who meet the criteria that they've set forth. Lung cancer itself, it's estimated by the American Cancer Society in 2015 that there'll be 221,000 new diagnoses just this year alone, and 158,000 deaths contributed to lung cancer. And that's a significant number. If you just put that in perspective, 158,000 is more than the combination of prostate, breast, and colon cancer combined. So it's quite a large killer, if you will, in the cancer family.
Yet we seem to hear more about prostate and breast than anything else, but this kills more than all of those combined. And more. That's amazing. So tell us about the low dose. I'm sure patients want to hear about low dose. They don't want radiation, so maybe this will help. Is helpful.
Well, every pretty much every modality in radiology, with the exception of MRI and ultrasound, uses some type of radiation. And medical radiation, it's called. And it's something that radiologists in general want to keep to a minimum and not overexpose patients for no benefit. So the low-dose lung screen uses a smaller dose for the chest CT. However, with the software provided, we're able to accurately look at nodules as small as 1 to 2 millimeters, despite cutting the dose significantly. And that's a benefit. The lung screening program is a program that isn't just once in the patient's lifetime, but if they meet the criteria to undergo the cancer screening, is something that they would have every year. So keeping the dose as low as possible obviously is a benefit.
Yeah. So we, in the past, we've never used CT for screening, and I know there was some demand for it and patients wanted CT for screening, but we were always taught that there's too much radiation, we really shouldn't do that, the risk is worse than the benefit. So things have changed.
Things have changed, and also it's the population that you're screening. The screening requirements for patients are in the age range of 55 to 77 years old. Now, as far as radiation safety and any potential harm that comes from radiation could happen within 20 to 30 years after a large exposure. So already the patients are in the 50s, 60s, and 70s. If there was any possibility of a problem, most likely those patients would succumb to something other than a radiation-induced malignancy. So exposing patients to medical radiation later in life isn't as near of a problem as a pediatric patient. Also, too, screening high-risk patients for lung cancer, if they have a 30-pack-year history of smoking, they'd be much more likely to develop lung cancer and die from that than any possibility of malignancy generated by medical radiation.
So 30-pack years is what?
30-pack years is simply a pack a day for 30 years. But you can manipulate that. If the patient only smoked half a pack, but they smoked for 60 years, that would also equal a 30-pack year history.
2 packs a day at 15 years.
Correct.
So it's just additive.
Mm-hmm.
Okay. So tell us more.
It's something that Radiology Regional has strongly adapted, and we're not the only one, actually. There are quite a few centers across the country that now have gotten ACR accreditation to have a lung screening program. And that criteria through the American College of Radiology, which is the ACR, requires that radiology groups or any medical entity that has CAT scans who want to go into the program to make sure they have a minimum level of a CAT scan equipment as far as the year it was developed, the number of slices. They require us to have physicians who have read at least 300 CAT scans within the last 3 years, physicians who are board certified, and radiologists who have up-to-date CMEs in CT, otherwise known as continuing medical education credits. So once those 3 things are satisfied, the ACR will grant us as a screening center, and Radiology Regional is one of them.
Well, we're going to take a quick time out, and we'll be back after just a minute or two to talk more about CT screening.
Thinking of buying a home located in a golf course community in the Naples, Marco, Bonita, or Estero, Florida? Here is what Mark Lai, former PGA winner, says about Realtor Michael York of the York Real Estate Group of Downing Fry Realty.
Hi, I'm Mark Lai. If you have any real estate needs in Naples, Florida, the one company to contact is the York Real Estate Group. Also, if you want a golf course property to invest in, Michael York of the York Real Estate Group is the guy to contact. Michael knows every golf course in Naples. I will tell you this, he's been in the golf business for a long time. He's played all the great golf courses down here, and he is an outstanding realtor. I've known him for quite some time, and he's got a lot of integrity, and he very much knows his stuff on all the different clubs here in Naples. So the York Real Estate Group is a great place to start. So if you have any time or anybody that wants to visit down here in Naples and look at the options out there, please contact the York Real Estate Group.
Welcome back to Dialogue with the Doctor. We're here today talking to Dr. Pagliara, a practicing radiologist with the Radiology Regional, and we're talking about low-dose CT CAT scanning for lung cancer detection. And we were just talking about the, pardon me, minimum requirements for readers. We were just off camera talking about that. Can you just reiterate what we were just talking about?
Right. In order to be ACR accredited as a lung screening center, the radiologists need to have a minimum of 300 CT chest reads or interpretations over the last 3 years. And they also need to be up to date as far as their continuing medical education requirements for CAT scan in that time frame. And they also need to be board certified.
Okay. Because you were saying some radiologists haven't read CAT scans in a long time because they're doing something else.
Correct, or they read CTs, but they don't read enough to meet the requirements. And I think if you were to have heart surgery, for instance, you would want to go to a heart surgeon that does quite a few of these for you to feel comfortable. And the same thing with reading x-rays and CTs.
Well, that makes sense. So tell us more.
I'd like to tell you a little bit about what patients fit the criteria for this lung screen. They need to be of ages between 55 and 77. They need to have at least a 30-pack year history of smoking. They need to be asymptomatic, as they're not short of breath, chest pain at the time of screening. They need to have a prescription in hand that states low-dose CT of the chest by their provider with smoking history. And those things will classify them as a candidate to enter the lung screening program. Also, too, is that we are required by CMS to keep a data registry. That is, when the patient comes in and gets their scan, the reader will assign a lung RADS, lung and RADS, basically a classification of the interpretation of their scan. And for instance, lung RADS category 1 is negative. So the patient would come in, get the scan. If I don't see any nodules at all, then it'll be a lung RADS 1 or negative. Follow-up from there would be every year. Patient has a nodule, but it's clearly a benign nodule, such as a calcified granuloma, which is exceedingly common. It would be a lung RADS category 2 or benign. And exponentially lung RADS go up for something that becomes more and more suspicious. Now, a lung RADS 4 is a nodule that is greater than 8 millimeters in size, which we're talking, very, very, very small still, but still we can categorize and classify it. That's a nodule that we would want to follow more carefully, either with another CT study in 3 or 6 months' time, a PET scan, which take a look at the metabolic activity of the nodule, and even larger nodules, if it's feasible, depending on where it is in the chest, we would actually try to get a little bit of tissue sample through a biopsy.
And how would you do that?
If there's a nodule that's suspicious, right off the bat, off the first CAT scan, or a nodule we've been following that has been growing, or a nodule that is hot, if you will, or metabolically active on PET, the radiologist would then make a decision whether or not it is feasible to needle biopsy the nodule under CT or CAT scan guidance. And depending on where it is, we would be able to do that in the hospital setting. It's under some monitored sedation to help the patient relax. Local anesthetic is given at the site of the skin where the needle enters. We use CAT scan to guide a needle to the nodule itself and take little tiny snippets of tissue, if you will. That gets sent to pathology, and they let me know, for instance, if I'm doing the procedure, if I have enough tissue for them to make their decision on whether or not we're dealing with something that's malignant.
So who does those procedures at Radiology Regional?
We typically will do them in a hospital setting, depending on the size and location, because small nodules near major vessels more dangerous, if you will, more risky than a large nodule up against the top of the lung, for instance. Typically we do them in a hospital setting, and most of our radiologists are capable of doing lung biopsies.
Yeah, it sounds not very inviting, but from what I understand, it's just technologically accurate and not all that bad of a procedure to have.
It's there's some risk with any procedure, as you know, but the goal is to catch the nodule when it's small, if it's a cancerous nodule, because that by far will portend to the patient's morbidity and mortality down the road.
So the screening guidelines, 55 to 70, why not younger? Why not older?
Well, that's a good question. There was a study that was done in the 2000s. It's called the National Lung Screen Trial, and that in the study itself used patients between the age of 55 and 79. It was funded by the National Cancer Institute, and 53,000 smokers or recently passed smokers were enrolled, and the data that was accumulated from following these patients over 7 years solidified that in this age group there was a 20% reduction in mortality using CT lung screen over the previous gold standard of yearly chest x-rays. The CMS used that data in their decision making to fund the screening program nationwide. Most lung cancers occur in that age group. You still can get lung cancer at an earlier age. However, if you take a look at the numbers, 55 through 77 grasps or captures most of the lung cancers that are diagnosed.
And older than 77?
After 77, I can only theorize why 77 was the cutoff. Again, the data that has been accumulated over the years went to 79 for those 53,000 patients. I believe there may be other pathologies that would end up killing the patient, if you will, after 79 rather than lung cancer, and maybe the yield after 79 did not statistically show an improvement in their mortality. So I believe that's the reason for the cutoff at 77.
So it's not a cost-benefit decision, is it? I mean, when CMS approves something, it's an approval for reimbursement. Does that directly correlate to science?
Well, in this political climate and of how cost-cutting measures and deficits and all that, I can't speak for CMS personally, why they stopped at 77. However, one can assume that eventually there will be a cutoff for a lot of screening programs, including screening programs in colon cancer and in breast cancer too. There's always a top end as far as when screening is no longer recommended by these institutions such as CMS or the United States Task Force.
We'll be back in just a moment to talk to Dr. Pagliara again about CT screening for lung cancer.
Thinking of buying or selling a home in Naples, Marco, Bonita, or Estero, Florida? Think of the most experienced York Real Estate Group associated with the #1 brokerage in Naples, Downing Fry Realty, which produced $1.9 billion in sales in 2014, controlling 43% of all transactions in Naples. Jim, Michael, and Morgan York make up the York Real Estate Group of Downing Fry Realty. With over $250 million in sales transactions, they can offer you the expertise and trust you want and need in a realtor. Call them today at 239-273-6727 or visit their website, www.naplesyorkrealestate.com.
Welcome back to Dialogue with the Doctor. We're here talking with Dr. Pagliara, practicing radiologist for Radiology Regional, and we're talking about CT CAT scanning screening, which has really never been done before to my knowledge, for lung cancer. And Now this program is just for smokers, is that correct?
That is correct.
Okay. So as I'm a family physician, we practice by the standard of care, we're supposed to. So are you saying that in my patients with 30-pack year history of smoking, I should be ordering this routinely?
Yes, this is the new standard of care.
Okay.
The data has shown the reduction in mortality is real, and I know that despite the radiation dose to the patient with the low-dose lung screen, the risks of that do not outweigh the benefits of catching a lung cancer early in this high-risk patient population.
We're used to doing annual chest x-rays. I think we talked about that before, which was a standard. So I don't do that anymore.
No, I mean, I think if you want to do what's best for your patient, obviously you talk to the patient and you feel how they feel about having yearly lung CTs. And you can talk to them and say, hey, this is a proven entity and this has a 1 in 5 chance of having you live a long life if you contract lung cancer. Mm-hmm. And lung cancer is a scary situation, as I iterated before, in regards to the number of patients who have lung cancer compared to the other cancers out there. So it behooves you to catch it early, and this is the best way to catch a lung cancer early.
Why don't you just briefly tell us about CAT scans? When I send a patient for, in general, a CAT scan, they don't know or understand what I mean. They think they're going to be injected with something. Can you just give our patients some idea of what they should expect?
Well, you'll be greeted by the CT technologists in our waiting room, and they'll walk you back, ask you a few questions about your history, make sure that you are the correct person that's on their schedule. We don't want any mix-ups. And you'll be walked into the CT room, and you'll be laying on your back. We would ask you to put on a gown and make sure that there's no buttons or jewelry in the region of the chest, so we have no artifacts. And you lay on your back, and the CT technologist will ask you to hold your breath. The scan time is usually between 10 and 15 seconds. So if you can hold your breath for 10 to 15 seconds, we'll have a crisp, clean image where there's no motion artifact from breathing. And that's it. You get up, put your clothes back on, and you walk out the door. Now, this is a test that's also paid for completely if you have Medicare and many of the third-party insurances. There's no out-of-pocket cost for this. There's no copay. This is a completely reimbursed, paid-for screening program.
Well, many of my patients ask if they're going to go in the really tight tunnel, et cetera, et cetera.
There is a tunnel. Every CT has a tunnel. However, it's very short, and it's not nearly as claustrophobic as the MRIs. So MRIs and CTs, even though that there's a gantry and the table which goes inside the gantry, the space is not quite as tight as an MR and are not nearly as long as an MR. So people who are even extraordinarily claustrophobic seem to tolerate being in the CAT scanner for short periods of time quite well. And also I want to add too, there is no injection of contrast, no dye, no IVs. This is done strictly without contrast.
Just lay down and... Well, the last CT scan that I was in was very narrow, I mean, compared to an MRI scanner.
Correct.
I mean, these are not even come close to the length of an MRI scanner, correct?
That's correct, yes.
Okay. So that sounds good. So where is this done in your organization?
We do them at 8 of our 9 offices, and very easy to schedule. And your physician, we have reached out to many of the local family practice, internal medicine, and pulmonologists in town with information in regards to the lung screening program with maps that can help you find any one of our 8 out of 9 offices that provide this service. The closest one to me where I work at is the Naples office, which again is on Goodlet and 7th Avenue North. And but our Bonita and our Estero office in the southern part of our territory offer it too. Lehigh, 2 on the Cape, and 2 in Fort Myers.
One thing I wanted to ask earlier was, this technology new, the CAT scanner itself? Is it a different type of scanner?
Same type of scanner, different type of protocol as far as how we acquire the scan, with the dosages we use, and the post-processing of the images to give us very thin cuts through the lungs, which creates a very detailed image.
So this is not like the ultra-fast CAT scans for cardiac imaging. Is it like that one?
You can have the lung screen on those scanners, the super fast scanners, the 64 slice, 128 slice, you can have it there, but it's not necessary. A 16 slice scanner can do the same thing, which is really the workhorse of the CT scanning industry, are your 16 and 32 slice scanners.
And is this technology throughout the country now? Is it everywhere, or is it just in large cities?
I think that your larger institutions, your hospitals, your larger well-known radiology or medical imaging companies will have scanners that are adequate and meet standards for the CMS to have this done. It's not new technology. However, you want to have a minimum speed of the scanner so the patient doesn't have to hold their breath longer than 10 or 15 seconds. And for most healthy people, that's not a big deal. But if you have someone who has a 30-pack-year history, a 15-second breath hold may be something else. So it behooves you to have your test done on a reasonably fast scanner.
Well, I have been a patient in your centers, and they're quite professional all the way around. And I think that patients will, once I educate them, they'll be coming. Yeah.
Well, super.
And
that's one of the reasons why I'm here, because I want to educate people about this.
Well, we'll send them over. I think this is a really very good thing to start doing. And I really appreciate you coming down and talking to us about this.
I appreciate it too. Thank you very much.
We'll be back, hopefully, again with Dr. Pagliara talking about something else,
I'd like to come
radiological
back.
in nature.
Absolutely.
Thanks for coming.
Thank you much.